My name is Andy Jones. I'm the CEO of Ramsay. Healthcare is a global provider of healthcare. We operate in 11 countries, employing 77,000 staff, and incredibly, we look after over 8 million patients a year. Ramsay Healthcare has been here in the UK for the last 12 years. We've now become the #1 provider for NHS services, which means that GPs are able to choose Ramsay hospitals to refer their patients for high-quality healthcare. So Ramsay has got a long-standing set of values called the Ramsay Way. They really define who we are as an organisation, how we work together, how we look after patients, and ultimately it's all about people caring for people. We're very proud of the services that we provide, and that's largely due to teamwork and our staff. The difference that this makes for patients is really high quality healthcare in all of our hospitals and facilities. We've got an absolutely fantastic programme called Speaking Up for Safety. It's all about training staff to be positive and to call out episodes in patients' care, particularly when they're concerned that things aren't going right. We've been able to grab this programme, and we're the first organisation in the UK to roll this programme out. The future for Ramsay Healthcare is bright both globally and for us here in the UK. All of our units are accredited for endoscopy. The Care Quality Commission has rated 92% of our hospitals as good, and 95% of our patients would recommend us to their friends and family. We're a leader in day case surgery. We've looked at the way that our hospitals are designed so that we can treat ever more patients in today's healthcare. The future of healthcare is all about partnerships and integrating the patient journey. At Ramsay, this means we need to be working very closely with all our partners, including the NHS, to make sure that our services are available in all the communities that our hospitals serve. Over time, I can see the company both growing and expanding in the reach of its services. But for me, most of all, patient safety and quality come first. Simply put, people caring for people.
Good evening. My name's Ian Sharp, and it's my pleasure to welcome you to tonight's lecture distinction on calcaneal fractures. Tonight's speaker is going to be Rob Clayton, who some of you know very well. He's a consultant in Fife since 2010 and did fellowships in, where did he go? He went to Glasgow and Toronto, and has a largely elective and trauma practice in foot and ankle surgery, but does a very complex foot and ankle cases. He's been on BOFAS SciComm from 2014 to 17, and has been the director of our media and communications since 2017. He's going to be hosting a BOFAS principles course in Dunfermline later this month. So I'd like to thank Ramsay for sponsoring our lecture distinction series, and now I'd hand over to Rob Clayton for his lecture. And if you have any questions to ask, please use the Q&A button in the Zoom app. And at the end of the session, you'll have an automated feedback form. If you fill that in, you'll then get a certificate to say you've attended the lecture. And I hand over to Rob for his erudite talk on calcaneal fractures.
Well, thank you, Ian, for the introduction. So yes, Robert Clayton. I work in Fife, which is in the southeast of Scotland, and calcaneal fractures. So we'll talk about what they are. We'll spend a bit of time talking about imaging, classification of fractures, and treatment, and contemporary treatments and more modern treatments, and a bit about outcomes. So almost all of this talk will focus on intra-articular fractures, and I'll add a little footnote at the end on a couple of the more important extra-articular fractures to round off. So the commonest mechanism of injury is a fall from height. So it's commonly young men, but it can be people of all ages. And the oldest person I've operated on is a 75-year-old woman. The primary fracture line is the thing we'll talk about, and I'll show some pictures from other angles, which is where the angle of Gisane on the talus penetrates down into the calcaneus, damaging the posterior facet, causing displacement of various parts of the calcaneus. So here's the anatomy. This is the sustentaculum tali on the medial side. The posterior facet is the bit that we get very interested in for displaced intra-articular calcaneal fractures, because it's this bit where the wedge of the angle of Gisane at the inferior aspect of the talus wedges in, cleaves off the sustentaculum, which is the constant fragment, and everything else falls apart around that. And then the middle facet and the anterior facet are sort of continuations of each other. And then at the front, important again in some of the more severe calcaneal fractures, is the calcaneocuboid joint. So we'll talk about the different types. Here are the 3 lines of cleavage. So you most commonly get with the displaced fractures 1, 2, or 3 of these fracture lines. And that's the basis for the Sanders classification, which I'll show in a minute, and which many of you will be familiar with, which is the most important classification system for calcaneal fractures. And then you get the secondary fracture lines. So there's the anterior, the primary fracture line. The sustentaculum fragment is the constant fragment. It tends not to displace. And then these other fracture lines develop around it with extension, comminution into the lateral wall and into the remainder of the posterior facet, and sometimes anteriorly into the articular surface of the calcaneocuboid joint. So these angles are much talked about. There's Bowler's angle, which you can calculate by drawing a line from the top of the anterior process to the high point of the calcaneus to the tip of the superior part of the tuberosity, and it's that angle there between the 2 lines. And Gisane's angle, which we tend not to measure quite so much, but is an important visual concept, and in particular when you're putting the pieces back together in your reconstruction. And so there's a normal calcaneus on the top, and here is a very flattened Bowler's angle, and you can see the depressed primary fragment in this joint depression fracture here. So imaging, of course, we get plain X-rays. Broden's views probably don't use those so much now, certainly not in the accident and emergency setting, but they can be useful intraoperatively to give you a series of different views of the posterior facet of the subtalar joint. Remember, the posterior facet is a sort of curved, it's curved in several dimensions. And by looking at it, these different angles, you get different angles of view which show you the accuracy of the reconstruction, and so that can be useful intraoperatively. I think it's largely been superseded for preoperative assessment now by CT scanning. And of course, here are your principal views. Your AP view, which is very useful, partly for looking at varus angulation of the calcaneal tuberosity. You can see blowout of the lateral wall, and at the front, if you get a well-angled AP view, you can also see what's happening in the calcaneocuboid joint. But CT scanning has changed everything, and really it's absolutely essential now for anything with displaced fractures, for determining whether you're going to operate and for determining what you're going to do on the table. So here's the coronal view. There's the sustentaculum tali. There's the posterior facet, and I'll show an example further on of how you can sort of scroll through this and get a really good picture in your own mind as to what's going on with the fracture and what it's doing. Classification system. So the Essex-Lopresti is the original classification system. It fell out of favor, but now it's come back into favor and is particularly useful for for percutaneous techniques of fixation. And in that classification, you've got the central joint depression fractures and the tongue fractures, and I'll show you a picture. The Sanders classification is the core one, and there are these other ones that are sometimes used as well. So here's the Essex-Lopresti classification. In this type, so here's the tuberosity. In this type, there's the posterior facet, and you've got this big tongue. So this is an Essex-Lopresti tongue type with this sort of beak that opens up at the back of the calcaneus. Whereas in the joint depression fractures, the posterior part of the tuberosity is usually intact, or in the more severe type, heavily comminuted. But this piece of the posterior facet is detached from everything else and is forced down into this sort of void in the center of in the center of the subchondral area. And as you reconstruct these, when you push this piece back up again, you're left with this sort of cavity underneath where all this cancellous bone has impacted into itself. But Sanders classification, type 1, 2, and 3. So I was showing the slide earlier with the three various primary fracture lines. And you can subdivide it, but I don't think people commonly do that. The subdivisions aren't particularly useful, but suffice to say that type 1 is where it's undisplaced. Type 2, there's displacement in one of these fracture lines, whichever one it is. Type 3, there's displacement in 2 of these fracture lines, so the posterior facet is in 3 pieces. And in type 4, it's all 3, so the posterior facet is in 4 or more pieces on this coronal view. So treatment, well, first of all, associated injuries. If someone's presented to you with a calcaneal fracture, the first question to ask is, what other injury do they have? So some studies suggest up to 80% of patients with a calcaneal fracture will have some other injury somewhere. And remember, they're falls from height, so it can be up in the lumbar spine, thoracic spine, opposite foot, other injuries in the same foot, anywhere. So look for it. Do a full secondary survey. And then, like all serious fractures, it's a soft tissue injury as well as a bony injury. Most of the pictures I show will be x-rays, but don't forget what's going on in the soft tissue envelope, because that really is crucial to what you're going to be faced with. Get x-rays, and as I say, a CT scan is really mandatory now. What should we do? Should we fix it? Well, we're all surgeons. We like to fix things, and we think we're good at it. But this paper came out in the BMJ in 2014 and caused a big stir in the foot and ankle community. The headline was very misleading, but also very problematic for those of us that do still see the importance of fixation of some of these fractures. Calcaneal fractures, surgery provides no benefits. Now there's a headline that has your department managers coming around to you saying, well, what are you doing? Why are you fixing this? It was a good study, but it had some significant limitations, and I'll come on to it. But there is controversy here. There are 3 key studies, 3 randomized studies, and the BMJ one is the 3rd one on this list. So this list will appear on the website if you want to go back to these, but 3 core studies. Some conclusions were that surgery was no better than non-operative treatment, but that's really at the margins and the ones that where the decision whether or not to operate is in the balance. And there are some criticisms of this. The main reason not to operate in all those studies is infection. And there's no doubt that infection, particularly with the extensile lateral approach, is a problem, which I'll come on to. But there are plenty of fractures that do need surgery, and they were excluded from these studies. So the first one is from Canada, and that was a big randomized trial. It showed that women do better with surgery, younger men do better with surgery, older men, and I'm almost in that category myself, apparently don't. Those receiving workers' compensation, which I suppose is the Canadian equivalent of someone suing their boss, don't do so well. And the heavy physical laborers, it seemed not to make as much difference, which perhaps sounds a bit counterintuitive. And not surprisingly, the better you could fix it, anatomic reduction gave better results, and the high energy ones, which were more common, did worse. But 5 times more likely to require subtalar fusion if they were treated conservatively. So that's a big difference. This study showed no difference at 12 months, but at 8 to 12 years, much better outcomes in the operatively treated group, which again, perhaps stands to reason, because one of the main reasons we're operating is to prevent subtalar arthritis. That's one of the goals of surgery. And the operative patients do take a while to recover from such a serious injury. And at 12 months, the recovery can take up to 3 years or more in a lot of these patients. So this is the BMJ study, which caused the great controversy. It was over 2,000 patients. It was multi-center across the UK. And it concluded that for Sanders 2 and 3 fractures, there was no benefit to surgery. And it showed a very high complication rate, 17%. But again, largely it was infection. There were some criticisms. And the main criticism is that so few of the patients were actually randomized. A large number of patients more than the number that were randomized. About 400 patients in total were deemed to require surgery and therefore weren't randomized into the study, which makes it hard to generalize the conclusion to include all patients. Poor reductions achieved in the operative group, well, they are difficult fractures, and actually the surgeons in the centres used were good surgeons experienced in fixation of these fractures, so perhaps that is more realistic of the real world that we're all faced with these fractures. But the follow-up was short, and that is clearly a criticism, particularly in comparison with that study from Sweden. So what are the absolute indications for surgery? Well, dislocations. That's the same with everything, isn't it? A dislocated ankle or a dislocated subtalar joint, more commonly. You might have all of the subtalar joint dislocated, or more commonly, a sizable portion of it. You've split the posterior facet and part of it's subluxed to the extent of almost being dislocated. And you can look at that and think, well, really, there is no choice to leave the patient like that. Subfibular impingement. So this is a coronal view, and here's the body of the talus. There's the fibula. So there's the sustentaculum, the constant fragment, pretty much undisplaced. And here is this entire posterior facet and tuberosity fragment that's been forced out laterally and proximally and is wedging against the fibula to the extent it's even avulsed a bit of the lateral fibula, which I've seen a few times. Clearly, if you leave the patient like that, they're not going to get a great outcome either. And so some of these, most people would consider absolute indications for surgery. Open fractures, well, we all know you've got to do something for these as well, but what you do is an entirely different matter. You may find that the soft tissues don't allow you to use any of the conventional sorts of internal fixation mechanisms that you might have had in mind. And beware, smoking and diabetes, very bad, particularly for the extensile lateral approach because of the risk of wound complications. Not a contraindication, but certainly a caution in both of these groups, particularly if the diabetes is complicated, i.e. they have any systemic complications, whether it's neuropathy or vasculopathy in the foot, or whether it's nephropathy, retinopathy, or other problems. So these are the sorts of problems people can get after the fractures if they're left untreated. Fibular impingement comes back to the slide I was showing a few slides ago, where you can get the impingement of the lateral wall. The other structure on the lateral side is the peroneal tendons. And so peroneal tendon, lateral wall blowout will lead to peroneal tendon entrapment and impingement. And in fact, I did a lateral wall exostectomy just last week for someone in that situation after an untreated calcaneal fracture. Problems fitting shoes. They're often left with a varus hindfoot, a very flattened, widened heel, which can be difficult to fit conventional shoes. So that alone can be quite debilitating for a lot of people. What are we aiming to do? Well, reduce the lateral wall. So I'll show the sections in a moment. You get this comminution of the lateral wall, which blows out as if you've sort of trodden on a ping pong ball that's exploded at the sides or something. So that can impinge on the peroneal tendon. So you're trying to reduce that. Restore the height of the calcaneus, correct the varus, and restore the posterior facet. Early mobilization is a goal, but it's not always realistic with these injuries, because quite often you will need to keep them non-weight bearing even after a good fixation. And clearly reduction of any sublux joints. So the gold standard operation, and still generally the standard of care, is open reduction. But percutaneous surgery is now stealing a march. But it's open reduction where the evidence base still primarily lies, and which was involved in the 3 trials that I was quoting earlier. So this is the extended lateral approach. And this is the one that is most useful for getting complete exposure of the calcaneus, to expose everything to give yourself the best chance of reducing as much as possible. But it's the one that worries us in terms of wound complications. It's a vascular flap, and you've got to cut, unlike, you can't go tentatively, you have to cut straight through all the soft tissue layers and not undermine them, and so you don't devitalize the skin edges. And this is interesting. This is a cadaver paper where blue wax is injected into the perforating perineal artery to show the zone of demarcation. So there's almost no vascular crossover between these two areas. So if you place your incision away from this line, you will have a devitalized area of skin between your incision and the zone of demarcation. And if you left that zone of devitalized skin, you are much more likely to see the wound dehiss and cause you major problems. Particularly, remember, as these patients almost always have quite a lot of swelling that puts the skin under significant tension. So bear that in mind when you're doing this approach. Keep the angle of the limbs at greater than 90 degrees. And once you're in there, you can then, once you've exposed the lateral side, this is the sort of comminuted lateral wall. You can peel that off and retract it round as a sort of osteo-periosteal hinge, which then gives you good access to the depressed fragments. And you can then put your periosteal elevator or Homans in, and again, the sustentacular fragment is the constant fragment, so it's constant. So this gives the impression you're lifting that up. You're not really, you're pushing the tuberosity down, but you're restoring everything around this sustentacular fragment. And then this is lifting up the depressed, you lift this piece out of the way and lift the principal depressed fragments up to restore the congruence of the posterior facet and restore the height of the calcaneus. So here's a case study. So here's a displaced fracture. You can see the fracture line extending down like that. So that's your plane X-ray. And on the AP view, you get the impression that there's a loss of congruence of the lateral third of the subtalar joint posterior facet. And this piece is probably veering towards impinging on the fibula. So this was a hard indication for surgery. So scan and plan. Now, everyone will have different PACS viewers, but if you've got this PACS viewer, it's absolutely wonderful. You go onto this MPR view and you can flip between the axials, the coronals, and the sagittals, and you can wheel of the mouse and you can see, so you can spend quite a while playing with these views. And you can even, I can't do this on this because this is just a screenshot, but you can change the orientation into any direction you want, which is really valuable for operative planning. It gives you a very clear idea what fragments of bone are where and what they're doing. So here we are going from medial to lateral. So first of all, in the sagittal views, there's the medial side of the posterior facet undisturbed, extra-articular, but as you come across, here's the big depressed fragment. There it is, dipping down into the calcaneal body. And then on the coronal views, as we go from anterior to posterior, through the posterior facet, you see the depressed fragment, you see the lateral wall, the blowout of the lateral wall, and the bits that risk impinging on the fibula. And similarly, on the axial views, here is the blowout of the walls, and you can see how wide this calcaneal tuberosity has become. And then these are the intraoperative views. And so what I've done here is I've done the standard extensile lateral approach that I was showing in the earlier slides, and then use 3 K-wires to retract back this big flap of skin. You put one into the cuboid, one into the talus, and one into the fibula, and you bend the wires back, and those act as your retractors so that you can then see the whole of the tuberosity of the calcaneus. This wire was being used to elevate this depressed fragment, and I put it across the subtalar joint to hold it there while I fix it, reconstruct everything else, push the lateral wall fragments back in, and apply a plate with enough fixation to hold everything where I want it. So why is it controversial? Again, soft tissue complications. That's the big reason. That's the big thing that gets us and our patients. This is a disaster. Sometimes when this happens, you might get away with vac dressings and vac treatments. You might need plastic surgeons to help. And in the worst case, there is a significant risk of amputation. But as I was saying before, there are risks of not treating it. Here's a malunion. Here's a very severe depressed fragment. You can see the damage to the subtalar joint and the complete misshaping and the impingement on the fibula. And in this one, the talus has sunk, the back of the talus has sunk down so much that the whole talus has ended up tilting in the opposite direction. So it's tilted into dorsiflexion, which means the patients often have anterior ankle pain as well as all the pain from the destroyed subtalar joint and misshapen calcaneus. They get this anterior ankle impingement. Malunion, there's the lateral wall impinging on the fibula. Wound breakdown, as I was showing earlier, leading potentially to deep infection, multiple operations, and a long, long recovery and a very poor outcome. So that has led surgeons to look at alternative approaches, a sinus tarsi approach and other percutaneous approaches. The idea being that by reducing the soft tissue insult, we reduce the risk of infection. So you can now get sinus tarsi plates that you can put in through a small incision directly across the sinus tarsi that can give you a good view of the posterior facet. Percutaneous fixation using periosteal elevators and systems of screws, which I'll show in a moment. And so this is evolving, but it's been these techniques have been developed for about 15 years now, and they are gaining significant traction. Good outcomes, good radiographic results, and there are increasing series of low-grade evidence. There aren't big randomized trials like there are for the extensile lateral approach, but some increasing evidence for their efficacy and safety. So I'll show a few of my techniques, and then we'll stop for questions. For the tongue-type fragments, you can lever the tongue down and fix with a couple of screws down the back of the tuberosity to hold the tongue fragment in place. And then the mainstay of the percutaneous techniques to me is use of full-length, fully threaded screws. They must be fully threaded, otherwise you'll just compress the tuberosity. Fully threaded screws, which act as a sort of raft to buttress up the displaced posterior facet fragments. And you can do similar. It's harder for the joint depression fractures, but you can sometimes achieve equally satisfactory results. So here's an example. Here's a tongue-type fracture. So you can see the the flattening of Bowler's angle and the displaced posterior facet fragment here. And you can see how that fragment is extending out through the back of the tuberosity. And in this one, I have made a mini sinus tarsi incision. You can see my self-retainer. I've used this wire to lever up the depressed fragment, put a couple of small wires for cannulated screws across, used a couple of small cannulated screws across the primary fracture line, used this to lag down the back of the tongue fragment, and then raft it up with these two full-length screws. And similarly, this one is a very similar fracture. This shows the sort of sequence. I start with a strong, big percutaneous wire directly into this displaced fragment, and then I simply lever it down. You joystick it round, so you can see how there it's very displaced, and as I'm pushing this wire inferiorly, that's elevating the fragment up and restoring the congruence of the posterior facet. Then I check a Harris axial on the table, put my long screws in to buttress this up to support this fragment so that it can't fall back down again, and I lag the back of the tuberosity. The joint depression ones are harder, and where there is comminution like this, I will need to make a small sinus approach so that I can lever the fragments back into place. But there are various tricks you can deploy. There it is, levered open. And a couple of screws across the primary fracture line. And similarly here, you can see that cavity I was talking about where the posterior facet fragments have impacted and squashed the cancellous bone down here, put in a periosteal elevator, use this to joystick it all round, and then various screws to lag back the primary fracture line and the rafting screws interspersed between them or to hold it up in place. So there are promising results for this, but it's not the be-all and end-all, and some of the more heavily comminuted fractures are very difficult to treat with percutaneous techniques, but by reverse, they're the ones where the soft tissues are much worse and harder to treat with open techniques as well. So a lot of the evidence from the randomized trials does not represent contemporary practice. A lot of us are now using percutaneous, less invasive techniques, sometimes arthroscopically assisted, sometimes with sinus tarsi plates, which are less invasive than the extensile lateral approach. It is clear that there are lower complication rates, but we don't have level 1 evidence and we don't have longer term follow-up in big numbers. So I think displaced fractures should generally be treated by restoration of the anatomy and congruence of the joint surface, just like you would elsewhere in the body. But be careful and be very mindful of what's going on with the soft tissues. Just a final couple of slides, I was saying a couple of key extra-articular fractures to know about. These are very important. This is the one calcaneal fracture that can't wait for the foot and ankle surgeon to come in and operate however many days later. The generalist orthopedic surgeon needs to be able to deal with this acutely, particularly if there's neuropathic skin, but even in normal healthy skin, in young people with this type of injury, if treatment isn't expeditious, this can happen with this distraction of tight skin over the back and skin breakdown and a disastrous outcome. It's urgent. You've got to get out of bed in the night and deal with this one. But thankfully, it isn't difficult. Some papers talk about opening these up with an extensile lateral approach and making life very difficult. You don't need to. For this fracture, that big displaced posterior tuberosity fragment, you can imagine how stretched the soft tissues are. You can't leave that for very long. But this is all you have to do. Get an X-ray, put the patient on their side, get a large AO clamp and squeeze it down. It's as simple as that. Squeeze it down and then lag it. Now I've used fully threaded screws here because I've used this isn't against AO principles. I've used the clamp to lag it, and I've then used this fully threaded screws because this patient was a little bit older and I wanted to ensure that there was proper grip. But you could use partially threaded screws in younger, healthier bone. It doesn't matter as long as you've got enough grip. Squeeze it down and lag it. It's really not very difficult, and it's a game changer and it's a disaster if you miss it. Avulsion fractures, you can get simple avulsion fractures of the anterior process. They can be surprisingly problematic. They look minor, they are minor, but some of them can cause significant longer term problems. So just be aware of those. We don't really know whether to excise them, graft them, or fix them if they're a problem further down the line. And the final type is this is technically an extra-articular fracture, but again, it's relatively easy to put 1 or 2 strong Steinman pin type wires in here, lever this round and lag it together with a couple of screws. So that was my run through of calcaneal fractures, a lot of time on displaced fractures, and I see some questions are coming in. So I'm very happy to take questions, and Ian will put any questions you have to me and we'll go through things.
Yeah, so whilst waiting for a few more questions to come in, Rob, do you think that BMJ paper actually changed practice in the UK or not?
I don't think it did. I think the foot and ankle community were too skeptical of its limitations, and I don't get the impression that there's been a wide scale change in practice. I think where it's useful is where the patient is right at the margin of equipoise. You know, you're looking at the patient and the X-ray collectively and thinking, there's no definite thing here. This patient isn't someone who definitely mustn't have surgery or doesn't need surgery, and isn't someone who definitely does. If it's really in the balance and you're not sure, then the findings of that study would suggest at the very least don't do an extensile lateral approach for them.
Yeah. And do you think there'll ever be a large study again like that when they compare percutaneous or less invasive techniques against open techniques or not?
I very much hope there is, because that paper is still very influential, and I very much hope that there will one day be a large study on less invasive techniques, to partly try and hammer out exactly where they work and where they don't, and to show that they are a good technique for certain types of fractures, or to show that they aren't if they're not. I would support high quality randomized trials for anything, and I do hope that that can be done, but the problems with pragmatic multi-center randomized trials are myriad, and so it wouldn't be an easy thing to set up.
No. And I suppose if you're not going to operate on a calcaneal fracture, what's your conservative management and how do you manage it through the process of recovery?
Good question. So if I'm not, I mean, I suppose it depends a bit, but in general terms, I'm worried that if I let them bear weight on it in the early stages, it's going to displace further. And that, there's no doubt that that can happen. So I would tend to keep them non-weight bearing in a moon boot for the first 6 weeks. And then I'd give them a moon boot because they still need it for symptomatic support for a further 6 weeks, starting to let them bear weight, and then on for physiotherapy.
Yeah. Okay. Cool. There's a couple of questions here about measurement of Bowler's angle and things like that, and calcaneal fractures. I mean, personally, I slightly tend to defer to the CT scan rather than measuring any actual angles on plain X-rays. Do you use those figures when you're assessing calcaneal fractures yourself, or not?
I don't routinely measure it. I mean, I have done for a whole series because I audited my own results of percutaneous fracture, and I wanted a fracture fixation, and I wanted to quantify in some way what I was doing. I audited them at a fairly early stage when it was too early to get long-term follow-up data. And so I did sit down and measure the Bowler's angle on all of the ones I treated percutaneously to see what I was achieving. And on that, I was using plain X-rays because I think the problem with the CTs is it's which cut you take. But in general, day-to-day clinical practice, I don't sit down and measure the Bowler's angle because it doesn't change. It of itself doesn't change my management. It's not that I'm going to say, well, this is 18 degrees, so I'm going to operate, whereas that's 25 degrees, so I'm not. It's more sort of marks for overall impression rather than one specific number.
Yeah. So in terms of the examination and areas like that for trainees, it's something they need to know what the Bowler's angle is for post-op measurements and an indication of what's happened to calcaneum.
I think it's important, and I don't want to dismiss its importance, but it is important to know what it is, because if you're looking for it, you are looking to see how depressed the joint is. We're talking about depressed intra-articular calcaneal fractures, displaced, depressed. If you're looking at it, you'll be thinking about the severity of the fracture. So I don't for one moment dismiss it. I just say I don't routinely actually sit down and measure the angle, but the concept is really important as a marker. First of all, when you're first starting out looking at these injuries, to make sure you don't miss it, and subsequently as you evaluate the severity of the fracture.
Excellent. So I suppose moving on a bit from kind of seeing the fracture, measuring it, now you're going to operate on it. In terms of swelling, do you have any particular techniques used to reduce the swelling, or how do you manage your patients whilst they're waiting for surgery?
So there again, it depends on what I'm going to do. If this is a fracture that I think is amenable to purely percutaneous fixation, so a lot of the tongue type ones where I don't even need to make a sinus tarsi incision, I want to get on and do those quickly. So even if they're swollen, I mean, it's all a question of degree, isn't it? But even if there's more swelling and even blistering than I'd be happy about for an open approach, I want to do those quickly because the bone fragments are more mobile if I do them within the first few days than if I leave them till 10 or 14 days, when percutaneously it's harder to dislodge the fragments. If I think I'm going to need a sinus tarsi approach, then if there's a lot of blistering or any blistering over where I'm going to make that incision, or if there's a lot of swelling there, I'm going to leave them for a bit. And if I do think they're one for an extensile lateral approach, then clearly I'm going to wait till the swelling's down enough. I don't have any specific techniques. Ideally, I like them to rest up with their foot in a brawn frame and have ice applied. But in today's world of very scarce beds for all our patients, they will often go home and come back, and I'm hoping that they'll be resting on their bed with their foot up on a few pillows, because there's not much more you can do. Even if they stay in hospital, some of them are quite itinerant and will get up and wander around for fresh air.
Yeah. So do you send them home in a cast or in a boot, or you don't mind?
It will vary. It will vary. Ideally, I'd like to use a boot, and so that they can take it off and apply ice. But I have to make a bit of a judgment, because if I think they're more likely to take the boot off and stomp around on it, I probably won't necessarily want to operate on them at all. But I might guard them by putting a cast on. But you have to be careful with casts, because with the changing of the swelling, they may swell more and the cast too tight. The swelling may come down and it rubs and it's loose and it makes the blistering worse. And the same actually goes for casting post-surgery. Most patients, I put a post-op back slab on with stirrups at the side, but if you do that, these patients swell and they can be very sore. So you need to be very careful with your post-op casts as well, the ones you put on at the end of the operation before you let the tourniquet down.
Yeah. Do you ever use a drain?
No.
No. And what do you close with?
I've never, but I don't think I have ever used one.
Yeah. I did very early on in my practice, and they always filled up by the time they got to recovery. So I said, clamp it, that's enough, and then carried on. When you're kind of looking at your posterior facet and trying to reconstruct things, do you think, are you more interested in the shape of the heel and the width and the height rather than actually trying to reconstruct the posterior facet? Or you...
I'm interested in the height. I do try to reconstruct the posterior facet as much as possible because intuitively it seems to me that that's probably the best way of reducing the risk of arthritis. So I'm going for the height and I'm going for the congruence of the posterior facet as my two primary goals. I think if I've got the height, then you've got most of the shape back. The other factor there is varus valgus, and the varus can be hard to correct, particularly open it's relatively easy, but percutaneously that can actually be quite hard to correct. You can sometimes put these wires in and joystick the tuberosity, or you can put the periosteal elevator across the primary fracture line and use that to try and lever the tuberosity out of varus. But that can be the hardest component to correct.
Okay, and do you ever think there's a role for primary fusion?
There is, and there are some papers that say that Sanders 4 fractures require primary fusion. I hesitate to use the word as strongly as require, but there is a role. But the problem I find is that the more comminuted the fracture, the more likely you are to think that's one for primary fusion, but the less you've actually got to work with when you do that fusion. You can take down the articular cartilage from the talar side, assuming there's no talar fracture, which there usually isn't. But you're left with a load of croutons in the calcaneus, and you're thinking, what is there in the calcaneus for that to fuse to? So I find there's a bit of a paradox there.
Yeah, and the other, I'm thinking all the things I've struggled with over time is the peroneal tendons, dislocated peroneal tendons, and that peroneal tubercle. Do you have any tricks and tips to how you kind of deal with the peroneal tendons as they cross that your operative field or the fracture area?
I mean, to me, the main thing there, particularly with either the open or the sinus tarsi approaches, is to fix back as much of that lateral wall as you can, which if you're opening it and plating it, is you just buttress the whole lot down with the plate. And then usually if you haven't left irregularities in the lateral wall, the peroneal tendons will find their natural course again. But you have often lost that sort of peroneal tubercle that holds them in place and some of the soft tissue attachment, so they can be hard to stabilize.
Yeah. There's a question just coming on the chat about the whether you use a bone block to achieve fusion. And I think, as Rob said, the problem with trying to do a primary fusion in a calcaneal fracture is it's all mush, and trying to get anything to fix to anything can be quite difficult. So I think in some ways, as long as you've got a heel-shaped heel in a Sanders 4, you can go and do a fusion later on. And then you get into a different argument about should you use distraction bone blocks to try and restore height, and some of the results of those are fairly poor. So I think that's kind of beyond the remit of this talk, really talk about how you fuse.
Yes,
later on.
I haven't gone into that because it is beyond the remit of this talk. I certainly do use bone block distraction for some if it's required. But what is in the remit of this talk, which I haven't dealt with in any depth, is that there is evidence that patients who undergo fracture reconstruction early, if they do end up needing a subtalar fusion, will get a better outcome than patients who need a subtalar fusion who haven't undergone fixation. And that's presumably because we have in some way restored something approaching the normal shape of the calcaneus, even if we haven't managed to save the subtalar joint. And so when you come to do your subtalar fusion a year or however long down the line, if you're starting that subtalar fusion with a reconstructed calcaneus that's something approaching the correct shape, the outcome is better than if you're dealing with a calcaneus that's been flattened down that you're having to reconstruct with distraction block graft and osteotomies or whatever other tricks you're having to use.
Yeah, I think
but that is a good reason to be thinking seriously about primary fixation, even if you think the subtalar joint's shot to bits and it's going to fail. If you can put the bone back in something approaching the correct shape, the patient will do better in the long term.
Yeah, a foot-shaped foot.
A foot-shaped foot.
Yeah.
Function follows form.
Yeah. And there's one kind of technical question here about where do you move the peroneal tendons when you're doing a sinus tarsi approach? Do you go plantar or dorsal with the peroneal tendons?
That's a good question too, because they're right in the way, aren't they? And so I'm working around them, and I'm often moving backwards and forth with either side of them. So I don't have a I do it this way answer. I am working either side of them, and often thinking they're right in the way.
Yeah. There's one other question here about why do you favour a reduction clamp for a ton-type fracture rather than the Steinman pin? As a Steinman pin probably gives a bit better control. I suppose, again, that's just what works in your hands.
Why do I? Well, so I suppose I showed both, didn't I, in different contexts. For the displaced tuberosity, this was for the extra-articular fracture. I used a reduction clamp rather than a Steinman pin because I'm trying to squeeze that fracture, that displaced tongue fragment down and lag it. For the intra-articular Essex-Lopresti tongue type intra-articular fractures, for those, my primary goal is to elevate the posterior facet fragment. So if I use a clamp on those, I will squeeze the back of the tongue down, but I won't elevate the posterior facet. So for those, I'm putting the Steinman pin in, and I'm using that to lever the depressed posterior facet up, and then the first thing to do is to hold it up before I lag the tuberosity down with screws. So my AO clamp use is only for the extra-articular ones, the ones that I say the non-foot and ankle surgeon has to get out of bed in the middle of the night to deal with.
Yeah, absolutely, yeah. So we're coming to the last few minutes now, because it's now nearly 10 to 9. I don't think there's no more questions to come through on the Q&A session. So I think there's an excellent summary of the calcaneal fracture management at the present time. If you look on the chat, there's the code for the feedback form was placed on chat for everybody. It's CE85R39, but it's on the chat, so you can fill that in when you do your feedback form, and you'll get your certificate to say you've attended the session. So it just comes to me to say thank you very much to Rob Clayton for giving it the time to give us a very good summary of how to manage calcaneal fractures at the present time. And once again, thanks to Ramsey Health for the sponsorship of this session. Next week on Thursday, there's a tour de force about biologics in orthopaedics and foot and ankle surgery, which is a combined session between the American Academy of Foot and Ankle Surgery and the UK BOFAS. So that's a master techniques lecture, which would be very good to attend, and some more lecture distinction carrying on each week. So thank you very much, and good night.
My name is Andy Jones. I'm the CEO of Ramsey here in the UK. Ramsey Healthcare is a global provider of healthcare. We operate in 11 countries, employing 77,000 staff, and incredibly, we look after over 8 million patients a year. Ramsey Healthcare has been here in the UK for the last 12 years. We've now become the #1 provider for NHS services, which means that GPs are able to choose Ramsey hospitals to refer their patients for high quality healthcare. So Ramsey has got a long-standing set of values called the Ramsey Way. They really define who we are as an organisation, how we work together, how we look after patients, and ultimately it's all about people caring for people. We're very proud of the services that we provide, and that's largely due to teamwork and our staff. The difference that this makes for patients is really high quality healthcare in all of our hospitals and facilities. We've got an absolutely fantastic programme called Speaking Up for Safety. It's all about training staff to be positive and to call out episodes in patients' care, particularly when they're concerned that things aren't going right. We've been able to grab this programme, and we're the first organisation in the UK to roll this programme out. The future for Ramsay Healthcare is bright both globally and for us here in the UK. All of our units are accredited for endoscopy. The Care Quality Commission has rated 92% of our hospitals as good, and 95% of our patients would recommend us to their friends and family. We're a leader in day case surgery. We've looked at the way that our hospitals are designed so that we can treat ever more patients in today's healthcare. The future of healthcare is all about partnerships and integrating the patient journey. At Ramsay, this means we need to be working very closely with all our partners, including the NHS, to make sure that our services are available in all the communities that our hospitals serve. Over time, I can see the company both growing and expanding in the reach of its services. But for me, most of all, patient safety and quality come first. Simply put, people caring for people.